Just previous to this position, I had the honor of serving President Obama as the White House, as director of the White House Office of National Drug Control Policy, known by a name that I never liked, which was the drug czar. And before that, served for 18 years at the Massachusetts Department of Public Health. So I've been doing this work for close to 30 years now. And I also say that I'm a person with lived experience. I've been in recovery for over 29 years now. So it's amazing. Don't do the math. I know these lights, don't do the math, because then you'll know how long I've been doing this work and how old I really am. But you know, part of this, a long time ago, a former federal colleague gave me a bit of advice that I have kept with me for a very long time, and that was, science and data are insufficient to drive public policy. That it's people that drive public policy. And I can't think of an environment where science and data are divorced from policy as working in the political arena, right? So think of climate change, think of immunization. We have this huge gulf between what we know to be true and how that gets reflected in public policy. And I can't think of any area of medicine and science where that gulf is so broad as it relates to our historic views around drug policy and people who suffer from substance use disorders. So I want to spend a little bit of time today talking about how did that happen, what were some of the attitudes that influenced that public policy, and how during my time with the Obama administration, we really tried to reframe drug policy and people with addiction as a health issue as opposed to a criminal justice issue, and how we did that in the absence of kind of the uptake of scientific information. So if you look at historic attitudes of addiction, you know, we have seen this as these are bad people doing bad things, right? So this is not a disease whereby we have symptoms. These are people who are doing bad things. And I can't think of any other area that had significant consequence, particularly for people of color, as it related to a punitive approach to dealing with folks. If people are bad, it requires a punitive approach as opposed to people with a disease who deserve a therapeutic approach to the work that we're doing at. And some of that is reflected in our language. So we often think of issues of addiction and substance use as a choice, right? So if you think of the term substance abuser, right? Abuse implies volition, it implies intent, and certainly there are behavioral choices that people make around those issues all the time. But we have a tendency to view this, people did it to themselves and they are bad people. So these are not kind of folks who are deserving of adequate and compassionate care. This issue is new to the world of science and medicine, right? So it wasn't until 1957 that the American Medical Association actually classified alcoholism as a disease, and it wasn't until the late 80s where drug addiction was classified by the American Medical Association as a disease. So we don't have this long history of scientific and medical advancements of this. And if you think of the care and delivery system, we have two different systems of care, right? So you get your mental health and substance use care over here, and you get your medical care over here. And you know, that is also evidenced by the lack of medical education that doctors, nurses, schools of social work don't get little to no training on perhaps the greatest and most prevalent disease condition that we have. So, and it's really, our attitudes are shaped by a variety of factors. So certainly many of us come from families with histories with people with histories of substance use. About 1 in 4 people have a family member who's affected by this. And often our perception of those people is colored by our experience with family members as it relates to this. It's also shaped by the media and media portrayals. And for those of us who've been following the coverage of the opioid epidemic, which, you know, at some level has been good to raise awareness, you would think if you listen to those stories that people don't get better and that people don't recover. It's really been kind of a one-sided media portrayal. And it's also reflected in the language that we use to historically talk about people with addiction, right? So we talk about them as addicts and junkies. And it's often, you know, it's often like linked with lots of other adjectives that are highly stigmatizing and are really separate from our understanding of a disease concept of addiction. And many people in recovery were and still are anonymous, right? So we didn't have this vibrant movement of people in recovery to show that people actually do get better. And as part of that, we still do not have a national recovery movement around advocating for issues of addiction. We're beginning to see that. But for instance, we don't have an ACT UP as it relates to issues of addiction and issues of overdoses that were remarkable in terms of changing federal policy in the landscape around HIV. So how does those attitudes manifest themselves at the individual level? So we know that those attitudes, that stigma, results in people avoiding seeking care, delaying seeking care, but we also know that it reflects itself in public policy. And this was a survey done by the Johns Hopkins School of Public Health in 2014 that polled people on their attitudes about people with substance use disorders, and they looked at it in comparison to people with mental health. And people with mental health issues don't fare much better, but you'll see some of the results of that polling where 43% of respondents felt like people with a substance use disorder were not deserving of a treatment benefit because, again, they did it to themselves, so why should we be providing them a benefit? 64% said employers should deny employment for people with drug addiction. For those of us who've been doing this work, we know stable employment is a big factor in getting people on the path to recovery, particularly those people who have criminal records as a result of their addiction. 54% said landlords should deny housing versus 15% for mental illness. And I think this is remarkable. Only 30% believe that recovery is possible for both illnesses. So despite the fact that we have highly effective medications, treatment strategies, interventions, we still have not broken through in terms of the fact that these are highly treatable conditions. And again, some of that is a function of this invisible recovery movement, right? So part of why I am so public about my own recovery is to encourage other people to be open about their recovery so that we can actually change that number and really change public policy. So how does that really impact, how do those things and those findings impact what we're doing? And I think you all know just the incredible morbidity and mortality with the opiate epidemic. In 2016 alone, 60,000 people died of a drug overdose, more than motor vehicle crashes, gun deaths, and the peak of HIV deaths. And I can't help but think, quite honestly, that we have tolerated. This epidemic has been building for 20 years, right? So this is not something that's just happened over the past couple of years. And I can't help but think that we have tolerated that level of mortality because of who's dying. Right? So I can't think of another disease condition whereby we would kind of not have the most robust and significant health response if it was dealing with another issue. And you think about this. So of the 22 million people in the United States who meet clinical criteria for a substance use disorder, only about 10% get care. It's really abysmal as you think about it. And if you compare that to another disease that has about the same prevalence rate, it's about 80% for diabetes. Of those that get treatment, it's mostly at the acute stage, right? And so the way that I talk about that, I'm sure you've all heard the expression hitting bottom, right? Think about how idiotic that is, right? So with any other chronic disease, say you have hypertension, we don't say to you, well, you have to have a heart attack before we provide structural and behavioral interventions to get you care. We don't do that. We have systematic interventions, and the entire focus of this conference has been about how we can precipitate behavior change through a wide variety of mechanisms. Despite the fact that it's a chronic condition, most treatment is of a very short duration. And I'm sure you've heard, oh, people need to go to detox or they need to go to rehab, right? So this is a chronic condition. People need long-term care for the work that they're doing. The vast majority of referrals, if you look at referrals to substance use treatment, so of that small portion, the vast majority of referrals are by the person diagnosing themselves, right? So someone has to come to the awakening that they have a substance use disorder. And our largest referral system is the criminal justice system, right? So we are waiting, so for those who are not arrested and incarcerated, we are waiting till an intersection with the criminal justice system as a leverage point to treatment. Only 8% are coming from our healthcare delivery system. So despite the fact that we know that this is a disease and a disorder, and we have high incidence of substance use disorders within our primary care settings and our hospital settings, we're doing an abysmal job. 50 to 80% of inmates have an SUD with greatest impact on people of color. So huge issues. So what did my office, and I have to say this, my office, my former office, we were established by Congress in 1988 to do two functions: to set the administration's national drug control policy, but also we had budget authority over those federal agencies to make sure that they were aligning with the work that we were doing. And again, I think about $28 billion in spending to deal with issues of drug use and its consequences. And historically, both the strategy and the budget had an overemphasis on supply reduction and law enforcement strategies. And by supply reduction, I mean, pulling coca in Colombia and eradicating poppy in Mexico and interdicting cocaine on the seas, right? And so if you look at the history of the federal drug control budget, it actually wasn't until the last year of the Obama administration that spending on health approaches actually equaled spending on supply reduction and law enforcement strategies. I have to say that the president's current budget proposal has that spending moving in the opposite direction again. And previous directors of my office were from military backgrounds and law enforcement. So I was the first person in this position with a public health background and the first person in this position to actually be in recovery. So how did we think about, again, so we have this great scientific evidence that this is a disease. We have a tremendous amount of understanding about how we precipitate behavior change and how we look at treating people with care and compassion. But despite all of that, we know that significant amount of our resources were still spent on law enforcement, on arrest and incarceration. So how do we think about, in the absence of science and data winning people's hearts and minds, how do we begin to think about using some other strategies to really change drug policy, not only at the federal level, but at the local level? And the first one is about how do we use personal narrative. I think is really important. So we, despite where we fall on the political spectrum, we are all subject to confirmation bias, right? So we have a tendency as human beings to disregard data that doesn't fall into our belief system and only validate those that do. And emotion appears to change people's hearts and minds more than science and data do. And I think that part of what has been, I think, incredibly impactful around particularly the opioid epidemic is the voices of parents who have been affected by this epidemic. And many of them, in the face of shame and stigma, have put in their kids' obituaries that their son or daughter died of a drug overdose. They have been incredible advocates at the state and local level and even at the federal level. So again, using their voice to really call for a much more compassionate response and a much more health-focused response, as well as using people in recovery. So how do we create this visible recovery movement to change people's minds? All one has to do is look back around LGBT rights issues to understand the role that visibility plays in changing people's minds and affecting public policy. So I think I was looking at data in something like 1987, only 26% of people in the United States knew someone who was gay, or at least someone who was openly gay. But that changed dramatically. Now it's about 89%. And clearly, when you look at the evolution in a very short time span of LGBT rights issues, one can understand the role that knowing someone changes your approach and changes your opinion of folks. The second piece is unexpected messengers. So how do we use unexpected messengers in ways to help promote drug policy? And I will tell you, probably the most powerful spokespeople that we have seen as it relates to a more public health response has been law enforcement. So let me tell you a story. In 2006, we were the first state, when I was the director of addiction services in Massachusetts, we trained the first police force in the country to administer naloxone. And for those of you who don't know, naloxone is this tremendous overdose reversal drug, and we knew we needed to get it in the hands of bystanders to diminish the mortality. And so we trained the police force in Quincy, Massachusetts, this small city south of Boston that has been impacted by this. And the biggest champion of change. And now we see naloxone distribution by just about every police department across the country was done by Lieutenant Patrick Glynn. So Patrick Glynn became the champion with other police departments in talking about naloxone. So instead of police officers coming back to the station talking about the arrests that they made, they started talking about the number of saves that they had, right? And so they really started talking about the miraculous change here. So law enforcement became really powerful spokespeople, not only about overdose prevention, but also calling for more treatment resources. I will also say that we had some unexpected messengers in very conservative congressional leadership. People like Mitch McConnell, Hal Rogers, who was at that point chairman of appropriations, I think were really helpful in terms of framing a public health related approach to this issue, largely because their constituents were significantly impacted by this issue. I also think that we've got to kind of state the obvious and put it on the table here, that the changing demographic of the opioid epidemic, largely affecting white communities, had a dramatic impact. And I think we have to acknowledge that, and we have to own that and say, yes, because not only of how widespread this was, but because of the color of the skin of people that it affected change our approach to this. And I think we have to own the fact that we got it wrong the last time, and we have the opportunity to get it right. But but we can't underestimate the role that the opioid epidemic played in terms of not only how prevalent and how personal it was, but also in terms of who it was impacting. The last thing I'll talk about is changing the language of addiction. So one of the last things we did as part of the administration, we put out guidance to all the federal agencies calling for the use of non-stigmatizing, clinically appropriate language for the use of people with a substance use disorder. And I will tell you, this is not about being politically correct. This is really about understanding that our use of language not only reflects our own feeling, but how we think about dealing with people with substance use disorder. So things like a person with a substance use disorder as opposed to a substance abuser. You will often hear people talk about their experience in recovery as being clean, right? So think of the opposite of that, right? And no other disease do we say people are clean and dirty, right? So we use this highly judgmental language. I will say that the AP Style Guide, which is the journalist's Bible and how they report, actually followed our lead and put out guidance to journalists around covering and appropriate language to use as it relates to issues of addiction. So, where did we end up here? And I have to say, I'm concerned. I'm concerned that kind of the current tenor of the administration has been signaling a return to some of those punitive approaches that I thought we made progress on. But I do say that it was probably one of the few areas across the political spectrum where we actually had consensus in terms of approach here. I don't know if that will change, but clearly, we had tremendous support from very conservative members of Congress. And I do think one of the reasons why we didn't see a successful vote in Congress repealing the Affordable Care Act was because they understood the role that played in treating people with addiction. I think we are beginning to see a shift in law enforcement and a retreat from arrest and incarceration. I think we've seen the evolution of these diversion models. One is LEAD. It's called the Law Enforcement Assisted Diversion Program. It's in place in Seattle and other communities where they're identifying people who have constant contact with the law because of a wide variety of issues and looking at getting them into treatment and support instead of incarceration. Another is called the Police Assisted Addiction Recovery Initiative. So this was an initiative started in Gloucester, Massachusetts, where the police chief said, regardless of criminal charges, come into our office and we will find you treatment and will actually case manage. So there's about 300 law enforcement programs across the country who have implemented that program, as well as wide-scale overdose prevention efforts. Many police departments are using naloxone to reverse overdoses. As I said, 2016 was the first time in history that federal spending for health approaches equaled law enforcement and supply reduction funding, and I think that that's really important. We were heartened that the Congress actually removed the federal ban on funding for syringe service programs, which is there was a decades-long ban on the use of federal dollars to support local syringe service programs, which is no small feat if you know Congress on this. We also, in spite of the fact that Congress did little to nothing in the way of legislation, we were able to pass the 21st Century Cures Bill, which gave over $1 billion to close this treatment gap for states and local departments. So it was really helpful for us in terms of being able to, again, how do we close that treatment gap and treat this as a public health condition? And as I talked about, the AP Style Guide calls on media to use non-stigmatizing language. So how do we begin to really deal with some of the highly judgmental language as we think about people with addiction? So I want to thank you all for being here today. I know we have a panel right after us, but I think the takeaways for me are, again, there are many areas, not only drug policy, where science is significantly separated from policy, and how do we use some of these mechanisms in terms of personal narrative and trusted and unusual messengers to help bring about and close that gap between science and policy. So thank you very much.